Good evening, everybody. Welcome back to CAEP's National Grand Rounds. I'm Tia Renouf and the new chair of the National Grand Rounds Committee. I'm an associate professor of emergency medicine at Memorial University here in Newfoundland. My work has taken me to indigenous and remote areas on all 7 continents, and I now research sustainable teaching methods in those areas. I have come close to the North and South Poles and can confidently assert that I returned alive. I'd like now to acknowledge the territory in which we gather as the ancestral homelands of the Beothuk and the Mi'kmaq. I'd also like to recognize the Inuit of Nunatsiavut and Nunatukavut and the Innu of Nitassinan, as well as their ancestors, as the original peoples of Newfoundland and Labrador. Tonight we have 4 great speakers to discuss best evidence in emergency medicine with a focus on vulnerable populations. At the end of tonight's session, you will gain an understanding of improving ED care for 4 specific vulnerable populations. The first topic is racial and ethnic diversity and will be addressed by Dr. Sunil Upadhyay, who is an associate professor of emergency medicine and health research methods at McMaster. He's a founding member of the BEEM faculty. He is also an avid scuba diver, mediocre golfer, and adequate jazz rock bass player with the famous Docs That Rock. The second topic is LGBTQ patients seeking ED care and will be given by Dr. Michael Cruz. Michael is a PGY2 in family medicine at Queen's with an interest in emergency medicine and 2 SGBTQIA+ health. A former advanced care paramedic at a busy urban service, he trains EMS who serve sexual and gender minorities. He is starting to build a research career on equitable care in the ED. He photographs insects and created a podcast on theater design called The Title Block. Our third topic tonight is pediatrics with Dr. Rahim Valani, who is an associate professor of medicine at the U of T. He is the director of the BEEM program. His interests lie in medical education and ED operations. He enjoys travel, having climbed Mount Kilimanjaro, has Everest Base Camp as his next target. Our final topic is geriatrics with Dr. Marcel Aymon. He is an emergency physician and trauma team leader at a level 1 trauma center in Quebec and an associate professor and clinician scientist at the Université de Laval. His research interests are trauma and geriatric care in the ED and has been a BEEM speaker for about 10 years. Aymon is passionate about rustic woodworking and lumberjacking. A bit of housekeeping. Please text your questions to the number on the screen or use the chat box as you think of questions. Thanks to those of you who have sent us questions in advance. I'd like everyone to know that there are no conflicts of interest, perceived or real, for this webinar. There has been no external support. So we'll get going and I will hand it over to Dr. Upadhyay to start. Dr. Upadhyay.
Thanks, Tia, and I'd like to thank the CAEP leadership for this most welcome invitation to present with our BEEM colleagues to our Canadian colleagues across the country tonight. As advertised, we'll be talking about the best of BEEM, which is the best of the best evidence in emergency medicine, with my peers, as you see here. We have 4 interesting papers that'll be discussed at upcoming BEEM conferences, and we're each going to take a turn on something that we have some interest and passions about. By way of disclosure, as previously stated, I'm an associate professor of emergency medicine and health research methods, evidence and impact, clinical epidemiology at McMaster University. I have no financial interests or conflicts of interest aside from my association with BEEM since inception in 2005. There is no financial supports or any other conflicts of any consequence with regards to this presentation. And for people who have attended BEEM, you know that this is a second order peer review EM relevant research summary operation to bring the best of emergency medicine and other research activities to international and Canadian emergency medicine audience. And this was founded by my friend and mentor, Dr. Andrew Worcester, here at McMaster. So diving right into it, the first topic I'll be addressing is race and ethnicity issues as they affect emergency department imaging. This is a systematic review that came up late in 2020 and is going to be included in this year's content. The recurring theme that you're going to hear about tonight is equity of care for different vulnerable populations and marginalized populations as they come to the emergency department in order to optimize their clinical outcomes and approach to care when they present to the emergency department. Regrettably, there are many, many examples of inequitable care in the emergency department. These can be based on various populations that are marginalized or vulnerable, like the elderly or children. Gender is a strong negative predictor of inequitable care. And as we'll talk about tonight, race and ethnicity. This isn't just about ED imaging. This can cut across other areas around analgesia treatments, which is a project we're working on with the Society for Academic Emergency Medicine Guidelines Group right now. Chest pain management, there's a rich literature on inequitable care for various groups, and on it goes. So the goal of the study for this review was to summarize existing evidence on any associations finding race and ethnicity as a predictor of utilization of appropriate emergency department imaging practices. So the authors are Shan Bauman and Gholam Rezanazad, and this was published in the Journal of the American College of Radiology in late 2020. The reference is here if you want to go look it up yourself. So the study methods they claim was a systematic review of 3 electronic databases, Medline, Embase, and Cochrane Library. There was a duplicate independent title and abstract review between 2 of the authors, including imaging studies based on race and ethnicity, clinical conditions being imaged, imaging modalities being looked at, primarily ultrasound, CT, and MRI, and then other potential confounding factors, including triage categories, history and physical findings, illness severity indicators, and insurance status. And then they did predefined subgroup analyses based on adult versus children. They excluded case reports, non-primary studies, and non-English language articles. Data was extracted, we presume, in duplicate and standardized forms, but that's not explicitly reported. There was no meta-analysis, unfortunately, because the heterogeneity of the articles that were included was too excessive. But they did get a fair bit of literature included, 42 studies, which had sample size ranging from 155 patients included from single center chart reviews to 2 million patients using administrative databases across national survey projects and administrative databases from insurance companies and so on and so forth. So lots of sample sizes here. Our critical appraisal stuff limited is that there is a bit of a limited electronic database search here. Most of the studies are from the United States, 41 out of 42, but there is one Canadian study that made the cut. We'll take a peek at that specifically. There was no analysis for publication bias. There's no formal quality assessments being done. So this is probably more fits in what Prisma would describe as a scoping review, not necessarily a systematic review. And finally, substantial heterogeneity between the studies that could have been attributed to study designs, various different classification schemes on race and ethnicity, variations in imaging studies being analyzed, and a few other major factors. But to cut to the chase, we'll just go through what were the significant findings. So the bad news is that in almost 3/4 of the included studies, various degrees of racial bias and ethnic bias played out, with decreased imaging rates for non-white and Hispanic patients that were anywhere from 10 to 50% less likely to be imaged appropriately compared to their white counterparts. And the odds ratio of not being imaged ranged anywhere from 0.21 to 0.92. Adult Black patients fared the worst. They were least likely to have ED imaging relative to their Hispanic counterparts and certainly to their white counterparts. And this did differ depending on the clinical condition being imaged as well. There were likely to be more striking differences in imaging for abdominal pain, but less so for head injuries and strokes. Sadly, children were not excluded from this kind of bias. There was a strong association of decreased imaging for non-white children, Hispanic and Black children across a variety of clinical conditions as well, mostly around abdominal pain and trauma. So these were the significant racial biases that were uncovered in this review. the strongest associations from imaging modalities seem to be associated with CT scans and X-ray. Non-significant, there were mixed results on race and ethnicity issues based on patients who had head injury, and this was borne out in both the adult and the pediatric population. So there was not as much discrimination against head injured patients, certainly not much evidence of discrimination or bias amongst adults with acute strokes. Disease severity, triage level, insurance status was not necessarily a predictor of differential imaging rates compared to race and ethnicity. And there were weaker associations of biased utilization using ultrasound and MRI across various indications, which is different from the significant differences we saw on CT and X-ray. So the Canadian article that was excluded, was included in this review, was from Bata et al. And so we pulled this out of CGEM. And this was an examination of equity of care in First Nations populations versus non-First Nations counterparts in the Saskatoon emergency departments. And they found that there was an initial signal potentially for differential imaging rates of First Nations versus non-First Nations visitors. But after doing multiple regression for adjustments for age and weekend presentations, this became a non-significant difference. So that's reassuring. So the authors here concluded that despite the heterogeneity encountered in all the studies that were incorporated in this review, patient race and ethnicity is linked to being under-imaged in the emergency department. The strength and directionality of these associations might be different between adults and children. It might be different based on disease severity and other illness predictors or severity markers. And there's more research that's needed to tease out what these underlying factors of differential inequitable care look like. So the takeaway for our perspective is that race and ethnicity seems to be an influence on diagnostic imaging decisions for various clinical conditions in the emergency department. It tends to generally work against Black and Hispanic patient populations, mostly in the States, not so much in Canada, but that may be an under-investigated phenomenon as opposed to non-existent. And again, sadly, children are also negatively biased by such decisions. So there is more research needed to explore multifactorial complexities in inequitable care in the ED for marginalized, racialized, and otherwise vulnerable populations. And obviously education and quality improvement strategies are needed to overcome such barriers to providing equitable care. And as ER providers, we should all be cognizant of any unconscious or implicit biases we have in perhaps making management decisions that may not be based on clinical parameters as opposed to demographic ones, including race, ethnicity, gender, age, sexual orientation, and so on. So we will take questions on this at the end of the presentation. I'll use this as a segue to introduce Mike Cruz and let him take over and talk about LGBTQ care issues in the emergency department.
Hello, thank you so much, Dr. Body. Yes, indeed. My name is Michael Cruz. I am a PGY2 in family medicine here at Queen's, and I'm joining you from the traditional territories of the Anishinaabe, the Haudenosaunee, and the Huron-Wendat here at Cataraqui or Kingston. I'll be presenting today on sexual and gender minority care in the emergency department, a scoping review that we recently completed and was just accepted into Annals with limited edits. Annals of Emergency Medicine in the US. Thanks to Dr. Blair Bingham, Daniel Bolishan, Dr. Melissa Wan, Alexandra Cliccio, and Dr. Sunil Patti for their co-authorship on this paper. And as indicated at the start, I have no relationships with financial sponsors to declare. So we'll just go through the different aspects of the scoping review we did, and then I'll talk about some future directions and research opportunities there at the end. You may be familiar with this long list of letters here, the 2S LGBTQIAAP. I won't go through what that represents, the identities that it kind of represents. I'll be referring to this population of sexual and gender minorities today. They make up about 4% of the Canadian population. This is from a June 2021 report from StatsCan. And this includes about 0.24% who identify as transgender or non-binary. This is an old estimate, it's about 10 years old. Newer estimates put this population at about 0.6% or higher based on who we talk to. And so this is a significant population in Canada, about 1.4 million people. Generally, SGM populations tend to have poor health. Some can't access primary care or a supportive doctor, so they may rely on the ED for their care. And there are some populations, especially trans and non-binary people, who may be avoiding the ED due to past discrimination and poor care. And because of this, we have identified the need for a clinical practice guideline that sets up, if we can, a standard of care. And this scoping review is the start of that process. We're basically asking the question, what literature exists on the care of SGM populations in the ED? So using the PRISMA scoping review criteria, we did a comprehensive research for all studies after 1995 up to January 2021. For SGM populations cared for in the ED in US and Canada. We limited this to the US and Canada because there are lots of cultural variations in the care and lives of sexual and gender minorities, and so we just want to be very specific about that. Then we did an ad hoc iterative and thematic analysis, and a reminder that this did not include a systematic review for bias or a meta-analysis of results. This is purely a scoping review trying to get a handle on what literature exists. And there to the right, we have the inclusion and exclusion criteria, as stated in my previous comment there. We did exclude any editorials, opinion articles, or letters to the editor, but we kept our net rather wide, including studies that were published as abstracts and conference abstracts. The search results resulted in about 1,200 studies that we found through our initial search. And after title, abstract, and full text screening, we ended up with 160 studies, which is actually many more than we ever thought we would find on the care of SGM people in the ED. After our thematic analysis, we came up with 6 themes: HIV in sexual and gender minorities, population health, which covers basically any kind of clinical or healthcare need of the population specifically, healthcare provider training, ED avoidance or ED use, and then the collection of sexual orientation and gender identity information, usually at triage. So let's talk about the results. HIV in sexual and gender minorities. This is a very heterogeneous population, with SGM populations representing a very small minority of most of the studies, usually as men who have sex with men, so it's behavior associated. Not identity. Key findings include many positive studies on the feasibility of testing for HIV in the ED, and the ED as a destination for HIV positive people who have barriers to primary care. Population health was the second largest. There was a high rate of mood disorders among sexual and gender minority youth, and a high risk in general in the sexual and gender minority community for suicidality. Some trans and non-binary patients have upwards of a 54% lifetime risk for suicide attempts. And that's a US stat. It's a bit lower in Canada. Provider training demonstrated a general discomfort in caring for SGM populations in the ED. And there's a paucity of training resources in SGM care in the ED and residency programs. And this was demonstrated in a recent CAEP subcommittee survey that you may have filled out. There's generally a reluctance to take care of this population because of an information deficit. Emergency department avoidance mostly focused on trans and non-binary patients. There's a high prevalence of discrimination was found in these studies, resulting in a large amount of ED avoidance, as well as an inability to obtain care in general. More recently, a non-published study from the Trans Pulse group in Canada showed that there's about a 12% avoidance rate in the last year of trans and non-binary folks avoiding the ED, and a larger, this was larger in the past, but it's still very significant. Emergency department use, ironically, there's evidence that people are relying on the ED for their care, mostly because of lack of access to care, and they tend to be sicker in general. Bisexual populations are especially represented in this sample, which is, I found, very surprising and is actually quite robust. And then finally, there's somewhat of a discordance between what providers thought was a decreased willingness to disclose sexual orientation and gender identity information, and a higher willingness to disclose on the behalf of the actual sexual or gender minority population. And generally, these were cross-sectional studies. There's not a lot of interventional studies that we found. So let's just talk about, I won't go through this entire list. I'll just focus on a couple things here. There are opportunities to do some systematic reviews in the HIV studies. We know that suicidality remains high. It's a significant risk factor in the ED for SGM populations. And there's evidence for continued discrimination. What we found quite remarkably is that there is a lot of missing data, specifically on intersex care. Only 3 of the 160 studies talked about intersex populations. So there is a real gap in the information about how this population is accessing and being treated in ED. Intersectionality, the idea that different identities can compound to affect one's privilege and access to services, is not represented in these studies. Social determinants of health aren't really globally or holistically addressed in these studies. It's very, very focused. And finally, elder care. Quite pointedly, the same generation that led the fight for queer visibility in the 70s and 80s is now having to go back in the closet as they get admitted to long-term care because they're co-housed with a generation that, I mean, to be quite frank, discriminated against them. And so we didn't find any studies that focused on elderly populations in the ED, and that was a real gap in our knowledge. And then finally, there's a lack of involvement of the 2SL LGBTQIA+ community in study design and implementation. Only about 9 of the studies included community involvement. So what do we do? Our next steps, obviously, there's lots of opportunities there to fill in the gaps in this knowledge base. This literature this study has allowed us to focus on a literature review of existing guidelines to see if they actually inform care of the ED. It's one of our research opportunities. Certainly, there's lots of opportunity for a deeper look at the outcomes for sexual and gender minority people and the effect of other social determinants of health on their ED visit and how sick they are. More importantly, we suggest that there is a need to engage with a diverse stakeholder population, not only within the medical system, including medical staff and nursing staff and admin, but also people in the community to find out how they want to use the ED and what questions are important to them, not just focusing on researcher-oriented questions. And this means that in the end, it's important to have a prospective creation of guidance documents that include the SGM community, using what we describe in the paper as evidence-based co-design, which is a process by which you train citizen scientists to be involved in the creation of the studies and make sure that they're actually answering relevant questions. So in conclusion, the current literature encompassing ED and SGM care clusters in these 6 themes as I described. There's considerable gaps to be addressed in optimizing culturally competent and equitable care in the ED for this population. And then future research to address these gaps should include substantial patient stakeholder engagement in all aspects of the research process to ensure patient-focused outcomes congruent with SGM values and preferences. So there you go. Well, again, have questions at the end. I'm welcome to all your questions. And now I'll throw it to Dr. Rahim Vellani.
Thank you, Michael. Give me a second here. I'm just going to share my screen here with everybody. And welcome this evening, everyone. To start off with, I would like to thank CAEP for inviting us to present Grand Rounds here today. And I'd also like to take this moment to acknowledge Andrew Worcester, which is somebody that Sunil had mentioned, who has been a mentor for both Sunil and myself during my tenure at McMaster and helping us, bring BEEM forward with this. My take on this presentation is going to be what exam features or diagnostic tests are helpful in diagnosing septic arthritis in an Olympic child. And as we're talking about different vulnerable populations, of course, pediatric patients are one subset of that in terms of finding the right diagnostic testing or appropriate management for different things. To begin with, I will also say that I do not have any disclosures that are related to this talk. So septic arthritis is certainly seen more commonly in children less than 4 years of age. The Canadian Pediatric Society puts the incidence as anywhere from 1 to 13 per 100,000 patients or children. And it most commonly tends to affect, the hip joint and the knee joints. In children, most commonly, the source is hematogenous, usually due to upper respiratory tract infections, things like Staph aureus, strep pneumonia, Haemophilus influenza, although the latter has been, not gaining much traction or has been decreasing in incidence and prevalence, given that we're vaccinated against this particular bug. In the younger child, 6 to 3 years, certainly think about bugs such as Shigella as well. And the concern is we don't want to miss this diagnosis because there are issues in terms of long-term morbidity and mortality, things such as sepsis, osteomyelitis, osteonecrosis, and joint deformity that can have long-lasting effects on it. And what we want to do is try and find a way that can help us predict which children are going to need further investigations and specifically going to need an arthrocentesis. So before we delve into that, are there predictors that will help us identify which ones will need that specific invasive test? Because I'm sure, as all of you will agree, we don't want to just be jumping and sticking a needle on any child. In an adult patient, if they've got a hot swollen joint such as a knee, it's routine practice for us to just go and do the arthrocentesis. With children, we think about invasive tests in a different way. And the question is, do we go and stick the needle into that joint, specifically the knee, or get interventional radiology to go into the hip? And what are the consequences of that? In the past, there have been 2 prediction rules that have been used, the COCA criteria, which most of you know about, and the 4 criteria. The COCA criteria are basically non-weight bearing, presence of a fever, white count greater than 12, and an elevated DSR. And during the derivation of this clinical decision rule, it had 99.6 predictive probability when all 4 were present. Unfortunately, the values were much less when they went to external validation. And in 2006, Caird and his group modified it to include CRP to the list. And one of the challenges with using ESR is it takes quite a bit of time for the test to come back. So most people have transitioned towards using CRP as a surrogate marker, and certainly understanding that if this is elevated, then it can also point in the direction of the child having septic arthritis. So how do we evaluate for septic arthritis in a limping child? This was a study published in the BMJ Open. And it looked at test characteristics of history, examination, and investigations in evaluation for septic arthritis in a child presenting with acute non-traumatic limp. And it was a systematic review, more like a scoping review, but it didn't have enough homogeneity to help us elucidate any good meta or bring it together as a meta-analysis to bring some good data out of it. So as I mentioned, it was a systematic review. The objective of the study was to determine the diagnostic accuracy of clinical findings and investigations in identifying patients that have septic arthritis. The study basically looked at compiled studies from 1966 to 2019 using 2 databases only. They looked at Medline and Embase. And there were 2 authors that extracted the data. If there was any discrepancies, then they brought in a 3rd person, and using consensus methods, then they agreed upon the final outcome. And their goal was to find identifiers, to identify articles that reported the diagnostic value of clinical, biochemical, or radiographic findings for differentiating septic arthritis in the limping child from other etiologies. Now, when you think of a child with a limp, there are various things that can cause it. It could be anything from a fracture, but if it's non-traumatic, then we think of leg calf perthes, we think of slip capitolofemoral epiphysis, and other diagnoses for which have better understanding of. In this systematic review, there were 18 studies identified that had over 2,600 children, and 560 of these with the final diagnosis of septic arthritis. When we look at the results, and I'm going to break these down into 3 different categories. The first is on the history and physical examination of the child. What they found is having a fever has a good positive likelihood ratio from anywhere from 2 to 25.2. The ability to weight bear is closer to between 1 and 2, and having joint tenderness markedly at 11.4. Unfortunately, joint tenderness and limited range of motion were less commonly assessed in these studies. In terms of the biochemical variables, as you know, we talked about the COCA criteria and Caird studies, and these looked at ESR and CRP. And again, The likelihood ratios were quite variable, up to 12 in either case, but as low as 1.2 in each when they grouped together. Interestingly, procalcitonin, a level of greater than 0.5, had a sensitivity of 97%, but unfortunately a very poor specificity. Procalcitonin has been used quite a bit in terms of determining serious bacterial infections in pediatric patients. It's used a lot in the US and in Europe. And there are very few centers in Canada that I'm aware of that have easy access to this test. It certainly is used as an inflammatory marker, just as the other ones, like CRP and ASR. But again, if it is elevated, it may point in the direction of some sort of infectious process going on there. Unfortunately, when they were looking at the gold standard for diagnosing septic arthritis in all these studies, there was no specific cutoffs that they used for synovial white count. Now we know, through all our studies and everything that have happened in the past, that a white count of over 100 is very diagnostic of a septic arthritis. If it's anywhere from 25 to 100, you're pretty much in that gray zone. And unfortunately, these studies didn't quite differentiate where exactly they put a cutoff. Neither was there a standard definition amongst all the studies. As far as imaging studies go, a presence of an effusion on ultrasound at the specific joint markedly increased the likelihood ratio of 8.4 for the child having septic arthritis. Characteristics that were found not useful: gender, specifically male gender, any history of tick bites, because you're thinking of Lyme disease at that point, prior antibiotic use, history of chills, or recent intercurrent illness. And again, the last one is there to help you distinguish septic arthritis from transient sinusitis. The conclusion was that differentiating children with septic arthritis from non-emergent disorders of non-traumatic lymph remains a key challenge for emergency physicians, and there's a need for more studies that are prospective derivations and validated that we can actually use in the emergency department. If we're thinking about limitations of this paper, unfortunately, it was confined to only 2 databases, and again, only in the English language, which certainly brings around a selection bias. They didn't go through Web of Science or CINAHL or certainly sort out through any abstracts. There were 12 studies of the 18 that were from the USA, and 5 of all the studies were prior to 2000, some as early as 1992, which, as you can imagine, can certainly change the frequency of septic arthritis, given that this was a time prior to Haemophilus influenza vaccination. There's significant heterogeneity, which limited the ability to pull the data for meta-analysis. This is called analysis-based bias. And certainly there were differences in inclusion criteria, definitions, cutoffs, and the gold standard diagnosis in terms of arthrocentesis. So there certainly is a need to develop prediction rules or high-risk criteria that can help us identify children with septic arthritis. And I think this is certainly an area that's ongoing, and we need to come up with a way that helps us identify children that need to go in for further investigation, testing specifically on arthrocentesis, be it through IR or us in the emergency department. So the take-home points, unfortunately, there's no single clinical lab or imaging finding that's useful to accurately rule in or rule out septic arthritis. Certainly the clinical decisions rules used in the past, while they're helpful and a lot of us tend to inherently use it, we don't hang our hats on it because they lack external validation to be clinically useful. And there may be a reluctance, as I mentioned earlier, to go and do the confirmatory joint aspiration because, again, it's an invasive test. Do we put the child through the whole process? They may need some sedation, et cetera, et cetera. And so do we continue to observe? Do we put a grab bag term? Again, there's a lot of unknowns that are out there still in this area. And I think more studies are needed for us to understand how to best assess these children. So at this point, I will pass the podium on to Dr. Marcel Amon, who's a colleague of ours with BEEM, who will take over.
Thank you, Rahim. I'm happy to be here. And as you said, I'm the last of the panel, but not with the least of the subject. So just as a start, I'm a faculty at the University of Laval, as it was told by the EMC, and I have no financial relationship except that I'm a BEEM speaker for the past 10 years. So this article about the vulnerable population, the geriatric population, caught our eyes, actually caught our ears, because that's about hearing impaired patient in the ED. And obviously, the EAR-VEI pilot study the hearing assistance provided to older adults in the emergency department was published this year by Chodosh and Al in the JAGS in 2021. This article is very interesting. As a personal note, my wife works as a hearing health specialist, and she told me about 10 years ago that I should do this kind of study. I didn't listen. So now I have to present a study from somebody else. But let's move on. What the study is about actually is about providing personal amplifier to hearing impaired patient in the emergency department. So the population was adults greater than 60 years old, English speaking. They were in the emergency department mostly with a severity index of 4 or 5, and some on occasion were 3 after the nurse assessed them and they could participate in the study. They had also a handicap inventory test of at least more than 10, or they self-reported hearing difficulties. Obviously, they excluded patients with unstable or life-threatening situation. The intervention they did in this RCT, which actually is an RCT pilot study, but still, the first intervention they did was provide personal amplifier during the ED length of stay of the patient and as early as possible in the process after the emergency admission. Comparison was standard of care, and the primary outcome that they looked at was 3 validated instruments: hearing understanding questionnaire, the care transition measure, patient understanding of discharge information. All those questionnaires are used and validated in past studies. They were not that often used in emergency department. So it's kind of a new setting for using those outcomes, but still quite validated in the hearing health specialist environment. And also a secondary outcome was return to the ED, and that was up to 30 days. They did measure that with a phone call and a follow-up phone call. So you're all aware that usually we have hearing impaired geriatric patient in our population. As a bald figure, when your patient are more than 65 years old, about 50% of chance that they have a form of hearing impaired handicap. And if you're greater than 75, it's up to 2/3 of the patient that have hearing deficit. So it's quite important, and we don't think of those in the emergency department, especially that the emergency department is one of the worst environment for listening and talking situation or environment. So what they did in the study basically, and I'm going to walk you through, is that as early as possible, as the patient came in the emergency department, they were randomized in 1-to-1, either to the intervention, and that's the up of your slide. So the intervention was having a personal amplifier. Here they use the pocket talker, which is a common personal amplifier. It's easy to use. Patient had a bit of training, standardized training by the research assistant, not a hearing specialist. They wanted to make it real life situation. And so it took about 5 to 10 minutes to have this kind of training. After the training, the patient was offered during all the stay in this emergency department to use the personal amplifier as they want when they had an encounter with the health professional. They were not requested to wearing all the time. As a control, they had the usual care. Of note, very important, patients with hearing aids were allowed to use the personal amplifier also on top of their hearing aids. At the end, around discharge, patients had outcome measures, and during those outcome measures, all patients, either control or intervention, were offered to have the personal amplifier, so make it easy for the survey that was on either an iPad or paper-based with the research assistant. So they did a very nice randomized control pilot study. There was not a lot of flaws. Actually, we have to mention that it's a small emergency department with about 11 beds. So they had probably a bit more time than in the busy emerge to set this up and do the pilot study. So now let's move on to the results. Very interesting. They have 133 patients that were randomized, 66 in the intervention group, 67 in the control group. Mostly were males, like you can see, and the mean age was higher than 75. what's interesting, and when we can tease out from the results of the questionnaire and the three instruments they use, is that there is no significance of voice being clearer for the patient, or the 3 days return or 30 days return to the ED. But when you look at other metrics that are very interesting, and I'm going to tell you why in a minute, is that understanding without an effort was positive. There was a ARR reduction, and there was an ARR of 19, so a good risk reduction there, and being more prone to hearing without any effort and understand without any effort. And understanding the management of their health, so for the patient, that's quite important. It's kind of patient-centered outcome. There was also an important reduction there, an interesting reduction. So for both of them, you have an NNT of 5 and 9 just by having a personal amplifier provided to those patients. And why is this important? Everything that's in green there, understand without effort or understand management of health, is that we're referring to the listening effort. Is that when you're trying to understand something, you have some cognitive task to accomplish, and having the listening effort being difficult or very overwhelming in those hearing impaired patients is competing with your cognitive function of understanding exactly what the doctors are saying, the nurse is saying, or any health professional. So they may be having more difficulty remembering exactly what you said. So that's very important for that vulnerable population. The author's conclusion was that veterans, sorry, I forgot to tell you, it was in a veteran hospital, but still really doesn't change the outcome for that kind of study. Veterans with hearing difficulties reported improved in ED experience with use of PAs, personal amplifiers, and were less likely to return to the ED within 3 days. Just for the last sentence, obviously it was non-significant. The study was not powered to do so. I'm just going back, but as you can see, in the 3 days return to the ED, there was really a difference in the number there. They didn't have the power to show a significant difference, but still, I think it's worth pursuing for further research. So this was a randomized control trial. So we're in the middle of the pyramid for the evidence pyramid, and there's a bit of threats, obviously, to the validity of the study. One of the threats was in the intervention group, there were a bit more patient coming with either a member of their family or a significant one than being alone. So there was more patient alone in the control group, which may have affected the understanding and the comprehension of what we're saying, and also the measures that were done after wearing the personal amplifier. And one other thing also we should note is that in the intervention group, there was more patient, there was a greater proportion with wearing hearing aids already in the emergency department when they came in. So already patients that were having their own hearing device on before they were randomized. Still, if we take those confounders into consideration, we do believe that it's a very interesting take-home message that we can provide to you in that vulnerable population of hearing impaired patients, that the ED environment, as I mentioned, is not hearing friendly. I'm pretty sure I don't have to prove that to you. You all have been working in the emergency department. But what's important is that the listening efforts competes with other cognitive tasks. And even us, we know that. I can tell you that in a busy recess room where there's a lot of noise and a lot of things going on, listening efforts sometimes to other colleagues competes with other cognitive tasks we're doing. So imagine when you're 75-year-old and you have really big deficit in your hearing. That could be very complicated. And this study shows that there is maybe some hope that offering a personal amplifier may lower the older patient effort in the ED and improve health management. And I can tell you, in those pandemic days where we're wearing masks, offering assistance like a PA could be useful for the patient. Also, there's been some studies showing that either in the elder population or even the adult population, that using pictorial discharge information along with maybe using those kind of personal amplifier may be quite useful to make sure that the patient understand what we went through during their process of care. So I'm passing back the mic to our MC, Tia for any question from you.
Okay. Can people see me? I'm back. I think I'm back. I think I can be heard. Lovely. Thank you all for these presentations. I think they were all well chosen and interesting and reflect your good work. While people are thinking about, from the audience, are thinking about questions to pose, I'm going to throw a couple out there. One of them, where we just finished, Marcel, talking about your study. I found myself interested in whether there was any difference between the groups that had hearing aids already and applied the external device versus those who did not have hearing aids and had the external device. I'm thinking specifically of things like feedback and issues that might scramble things in hearing.
Oh, it's not supposed to have any feedbacks if it's well set up. You can use them usually over the hearing aids, and the audiologists have been doing that for many years. I can tell you from home experience, and you can do that even over the hearing aids because it's just basically amplifying the sounds that goes to the hearing aid basically. So it can work. Obviously, there's always a bit of technology there, and yeah, you can have some feedback, but it's not a common reported adverse event in this study.
Yeah. And on the absolute bottom of the evidence pyramid, I have a question just of personal experience. How many of us have tried the old stethoscope in the patient's ear trick and speaking into it and found it useful or not? COVID.
That's a trick of the trade, but it doesn't really work well when you have the hearing aids of the patient on.
Good point. Obviously, I mean when they don't have the hearing aids.
Yeah.
I don't know. I've used it on occasion.
Tia, if I can interject, there was a question in the chat from Eric about the cost of these devices. So if you were to shop on this on Amazon.ca, in Canadian dollars, the cost of these specific devices used in this study range from about $249 to $300 each.
Yeah, but the pocket amplifier that you can get on Amazon on occasion is more around 130. So I mean, it's not that expensive. Obviously, there is issue with all the, I would say, the infectious, infection that can be transmitted. That's something you need to take care of, but and preventing those. But obviously, it's not that expensive for changing maybe a setting in where we're a bit lacking as emergency physician.
Yeah, it's interesting. In very poor communities, that would still actually, I think, be a barrier, that cost, and the general reluctance for people not to wear hearing aids sometimes because they're a nuisance. I'm talking about my experience in very remote rural settings where.
One other proviso, if I can, Tia, is that because this study was set in a U.S. Veterans Administration hospital, it was commented that the participants who were using these devices got to take them home, which was it's an interesting, and I think because they all fall under the U.S. Veterans Administration umbrella, it's just another service and/or product that they would be covered for within the VA system.
Right.
So that would take care of the infection control issue if they just get to keep the device and take it home, right? So
yeah, that's right. Sounds good.
Yeah.
We have a question from the crowd. Helpful session, thank you. It's notable, however, that there are no female speakers tonight, particularly given the theme. Could the speakers please reflect on this and share their thoughts?
There's a lot of female speakers that are going to be joining the courses. I can say that. And Marcel, you've got the next one coming up in Quebec, so maybe you can speak to that. Well, it's next week, I suppose.
Yeah, out of the 7 presenter next, the 8 presenter next week is actually 50%. So we have 4 ladies with us and 4 male that way. So we're trying to be equity there.
We've been recruiting. So if there's people who want to jump in on the bandwagon, we would happily bring them on. Bring people. Anybody who wants to join can join.
Sounds good. And don't forget the boss lady here, the moderator, the chair is a woman. So at least to have a nominal presence. Another question I was thinking was, let me just check my notes. Where are we? Yes, for Mike. I was very interested to hear about the gap in non-binary individuals in nursing homes, having reached that age where that's where they go, and the discriminations against them. Have you any thoughts and plans on how to move forward and evaluate this?
That's a great question. So I don't have a lot of knowledge of the non-ED literature when it comes to long-term care. I know that people are studying this. And it goes across the whole gamut as well. It's not just trans and non-binary folks. It's folks who identify as basically non-heterosexual. And I know that in Toronto, there's a movement actually to have queer-centered long-term care facilities that are specifically serving that population, which is not surprising, because when the AIDS crisis was around, like, I mean, it's still here, but when the AIDS crisis was at its peak and brought with it a lot of discrimination, the community itself rallied to get care for its own members, right, with Casey House and other kind of hospice models. So it is coming out of the community. As far as the research goes, I think there's a definite gap that we need to address in the ED care. I think that proper risk stratification and probably identifying these patients in order to get them the services that they may not be getting inside the long-term care facility will be helpful. And that goes along with this question of actually collecting the sexual orientation and gender identity information at triage and doing that in an equitable way that improves care and doesn't stigmatize people. And so I think that's the first step, is to identify the population. So that's one of the things that we're going to be working on in the future.
That's
so
an interesting point.
If I'm add to that, sorry, Tia. Michael, you had mentioned one of the buzzwords there in your slide deck, which is intersectionality. And this is a prime example. Kimberly Curlew coined the term probably 2 decades ago. She's from out west. I think she's at UCLA right now, if I remember correctly. And her initial paradigm fit on being a Black person and being a female, and you keep adding these layers and the intersectionality that adds to it. And this is classic because you've got a minority group or an underserviced population or an underprivileged group, and now you've added ageism to it, where now that intersectionality is prime area to study it and see how we can help those people, because there's going to be biases that the other residents may have because they come from a different generation. And this intersectionality concept is really big, because now what if you add another layer such as race as well in there? Because remember, these people were also from that generation where racism was part of their culture as well. So now you keep adding extra layers on top of it. It's such a rabbit hole that you can go down into, but I think it merits further studies and abilities so that we can make the lives of our aging population better. If they want to go to a nursing home and get the care, they deserve that care. If they want to come to the ED, they deserve that care. There shouldn't be any biases, or we should try and remove the biases and stigmas that are inherent within us. And I think the other piece is, some of you may have taken that Harvard inherent bias stuff, and I think Stanford's got some stuff around it as well with their courses that you can take. These are all areas that can help us become better clinicians and better listeners to our patients.
Yeah, good point. That's really what it's all about at the end of the day, isn't it? Walking in their shoes. I think it's great, the acknowledgement that identifying somebody's sexual orientation or anything else, or transgender status at triage is the way to go. But that can be very delicate and tricky as well. So we need substantial educational efforts in that direction, I think. Thank you. One final question from me, as somebody in the group has one, and that's for Rahim. I'm interested in septic arthritis in kids, Rahim, because I've done a lot of Indigenous emergency medicine around the globe. And it strikes me that those populations are hugely prone to sepsis in general. And in a Maori emergency department I've worked in New Zealand, population being 60% Maori roughly, it was joint infections were uncommonly. I mean, you would assume it was a joint infection before you moved on. And I'm wondering how do you perceive the proper way to move forward in the setting where it's incredibly common, incredibly busy, and you don't really have time to aspirate joints, although we certainly did tons of them.
Yeah, and that's a great point. So first, to begin with, a lot of these studies may have been carried out, as you can imagine. You know, they're published. They're probably done at urban centers or pediatric-specific centers. You know, when you get into rural populations, indigenous populations, high-risk populations, I'll give you a classic example. You know, when I was a fellow at Sick Kids, you know, a kid comes in with a swollen knee, basically from the Philippines, Cuper's back, tapped his knee. He's got TB. So TB is rampant in these areas, right? In these indigenous populations, we're going to see a lot more TB. A good paradigm or a good analogy would be, you know, in North America, a fully vaccinated child that's, say, you know, 3 years old, most likely they've got a viral illness, right?
Yeah.
In sub-Saharan Africa, you have fever. It's malaria until proven otherwise.
Yeah.
It's certainly geographically dependent. So to your point, you know, immunizations may not you might not have a good uptake of people being immunized in those communities. So Haemophilus influenza comes up, TB comes up, and there's a lot more things. So in those particular situations, those are high-risk situations. I would say, yes, if you can tap the joint, certainly it would help in the diagnosis, but I would say that comes higher on the differential than the transient sinusitis. You know, here's some Advil, see if you can walk around the ED. You look a little bit better. I'm not quite sure I want to go and stick that needle in your knee or send you to IR, which may not happen today, or transfer to your pediatric center if you're working in the community. So there's a lot of variables. We kind of like, you know, hold back, so to speak, because it is an invasive procedure.
Yes.
But like I said, if you're in the high-risk areas, you know, in endemic areas, then all bets are off. You have to be more aggressive than in those situations.
Yes, and also in emergency departments in very tiny towns, sometimes there is no capability to aspirate a joint, and yet we often find that pediatrics consultants sometimes really are quite unhappy to empirically start antibiotics without all the information.
And understandably so, because the prolonged duration of the IV antibiotics and switching to oral and stuff like that. But I think, you know, depending on your resources, right? Yeah. If you are in a small remote community, you know, then you may need to start the antibiotics right from the get-go. Try and get the blood cultures, because remember, most of them are hematogenous spread. If you can get a sample, great. If you can't, I wouldn't take the chances, especially if it's a high-risk population with either TB or that's not vaccinated, or, you know, there's an obvious, like, you know, erythema around the area, quite tender. You know, you meet some of the COCA criteria, care criteria that are there. Absolutely.
There's also anti-vax is on the rise in these areas of New Zealand, and not just for COVID, but everything else. So we're seeing lots of these things resurge. And unfortunately, in that population, I've never witnessed a faster transition from somebody with a septic joint to sepsis in a heartbeat. So yeah, it's going to be, I appreciate your support for sort of flying by the seat of your pants when you have to.
Unfortunately, you have to, it's based on the circumstances of the place you're practicing out of. You know, I've done the tertiary care, pediatric quaternary care teaching, and, you know, some of my training there, and then I've practiced in the community where you don't have those resources as well. Yeah. So I get what you're saying.
Great. We have another comment from the crowd. Given the paucity of clinical data points to confirm or deny the presence of septic arthritis, what is your approach to the management of the limping child? We end up with consult peds.
No, and that's a fair enough question. I think, again, based on the history and the physical examination, that's where you kind of depend. You know, is there a history of fever, weight bearing, pain on palpation, pain of the joint, erythema over the joint, recent intercurrent illness, recent gastro, those kinds of things, you know, that you're going to tease out, that'll help kind of move you in different directions. I do tend to get a plain film. So let's talk about the hips. I think the hip is the most common one that everyone kind of worries about, because with the knee, you know, most of us can be comfortable doing an arthrocentesis, but the hip you have to certainly, you know, send to IR, and I don't think many people are comfortable tapping the hip joint. So once you've done that and getting some of the blood work, I think that helps guide me in a certain way. So, no white count, no CRP, blood cultures have been drawn, child looks well, given some anti-inflammatories, they're working on the department, they're flying around, there's no history of fever. I might choose to observe them, which means either observe them in the ED for a few hours or refer to peds at that point just for observation in the hospital, or send home with good instructions on when to come back, right? Certainly if there's any worrisome signs, red flags, one of the things I should have mentioned, I do plain films on them as well, so x-rays. Okay, because that can help me rule out certain things. So for example, if it's a skiffy or leg calf perthes, then it helps me clinch the other diagnoses. And if not, then like I said, if the x-ray is good, everything else looks fine, bring them in for reassessment. Give parents good instructions. And if, unreliable parents, then get them admitted to peds. If they're high risk, so if there's a history of fever, they're not ambulating well, any of the signs we talked about, erythema, quite tender, painful joint, they're crying, they're irritable, I'd have a low threshold to refer that patient on to a center that can do the arthrocentesis, or if not, then start the antibiotics on spec.
Yeah, just to be devil's advocate a little tiny bit, I'd like your opinion on whether you think decision rules are going to turn out to be particularly helpful in diagnosing this. I mean, we know that they're good for things you can easily palpate, like an ankle or a C-spine.
Right.
But for more systemic problems, I'm not so sure.
Sure. And I just presented rounds this morning on appendicitis, actually. And, we were talking about there's at least 8 different clinical decision rules for appendicitis. I think clinical decision rules can be helpful in ruling out. They're not helpful in ruling in. That's been my experience. So with appendicitis, there's a Alvarado score, pediatric appendicitis score. When you look at all of these put together, it's a low risk, a low probability that reassure you, normal white count, patient can ambulate, no fever. That's reassuring. I think when you start getting into, points above 1 or so, or even 0, if there's only 4 criteria, then you're kind of in that gray zone, right? And you kind of have to decide, are you going to proceed on with the next step, or are you going to observe further? And I think that's seen with a lot of clinical decision rules that especially in the pediatric literature, that is around these sorts of things, like with appendicitis as an example I mentioned, and with septic arthritis as well.
Yes, I guess it's really, there is nothing that beats clinical gestalt, even with its limitations, but that takes time to develop. And if you're a junior, new learner,
I think Sunil had a point there as well.
If I can add, and I would defer to our friends in Ottawa, who are obviously the global experts on the CDR stuff. But one caveat with CDRs for this topic is you need enough event rates, and septic arthritis diagnoses, I suspect, are actually quite rare. So it may take a long time and large numbers of patients screened to be able to validate such a rule. But again, the pediatrics experts and the Ottawa CDR experts probably could opine on that better.
Yes. Okay, so I'm not getting any more text questions, so it's time to wrap it up. And I just want to mention to our listeners that these rounds are held twice monthly. The next one coming up is on September the 2nd, and it has to do with leadership. So please tune in, and sincere thanks to everybody who took time out of their crazy busy schedules to help teach some EM best evidence tonight.
Sorry, Tio, did you mean October 2nd?
No, September 22nd.
Oh, 22nd. Okay, sorry. I thought you said September 2nd. It's like, no, that was last week. Okay. Okay. Just checking.
September 22nd.
I need a personal hearing aid to help with me for that, so that would probably help.
Okay. Well, good night, everybody.
Thanks very much, everybody. Have a good night.
Thank you, right.
Stay safe out there.